go ahead with Dr. Haldipurkar sir's talk. Very warm welcome to you, Dr. Haldipurkar sir. We are so happy and really thank you so much for joining in here. Please share your screen, sir. I'd like to invite you to give your talk on management of posterior capsular rupture.
Anaga, I would like to thank you for making me part of this, a real team of exceptionally good surgeons. And thank you so much. And Sandeep, as always, you have brought out really good points on your talk, and you've done great justice. Well, management of PCR is definitely an important topic because PCR is the most common potentially site-debilitating complication during surgery. And all of us, in fact, all the faculty members also have somehow at the time faced a PCR once in a while. And the studies, various studies have shown that surgeons in FECO training, sometimes their PCR can go as high as 10 to 11%. An ounce of prevention is worth a pound of cure. And it is so true when it comes to dealing with posterior capsular rupture. There are some predisposing factors that we have to look at. Talking about eye-related factors, obviously a deep orbit or reduced visibility because of corneal few opacities, or a shallow AC, sometimes a small pupil, a floppy iris, weak zonules. Definitely these are not the cases a beginner would use because they have higher incidence of PCR. If you talk of lens-related factors, that may be things that you really need to look at. It could be intumescent, it could be Morgagnian cataracts. Obviously, posterior polar has documented higher incidence of PC rupture. Even high myopia, sometimes post-vitrectomy, or someone who's undergone several intra-VEGF injections. Trauma, obviously, and pseudo exfoliation, are the cases. See, we know that posterior polar cataracts are definitely, have a higher incidence because there's a inherent PC deficiency or a weakness in the PC. So when we do a PC posterior polar cataract, we are all the time careful. All the care that is to be taken, we do. In fact, in this case, after the good hydrodelineation, the nucleus is lifted out and it's properly removed. And now I know that the major worry is over. And then you go into your epinucleus mode, and very, very gradually you try and dislodge that plaque. And you also succeed very much in dislodging it. And now you know that most of your fight is over. And then, of course, we also know that in a posterior polar, you would never want your AC to be shallow. So before your phaco tip comes out, you go with the irrigation, keep the chamber maintained and come out, and then go with the irrigation aspiration to get most of the cortex out. So by this time, you're sure that you've done it and you've come out successful. But not necessary, because sometimes these capsules are inherently weak. Now, what has happened is I'm waiting to push in viscoelastic and put a lens inside, and that's the time the PC gives way. So sometimes if you have a posterior polar, it is better that till the end you take care. Now, sometimes situational related issues could also be there, like if you didn't have inadequate anesthesia, or there were excessive eye movements, or even the positioning was not proper, or sometimes because of obesity and short neck, you have vitreous pressure. These are all cases where you can get PCR. So when do you get it most? Mostly when you're dealing with the last nuclear fragment. It could be often during stage of irrigation or aspiration, sometimes during PC polishing, at times during early or mid phaco when the phaco tip inadvertently passes through the nucleus. So in short, you can get it at any stage. Now, this is a classic case. You would always see a resident or a novice phaco surgeon doing his last phaco piece, last fragment. And he's, this is very, very common to get it because he has not stuck to the principles. The principles are, when you are, you have to have a good control on your foot switch. When you're on your last piece, probably you have to reset your phaco parameters. Now, these are some of the basic things that, we have to take care of. So let's look at the cardinal signs of a torn posterior capsule. The very commonly, very rarely people get to see, but if you see, you never forget, that's a pupillary snap sign, which is sudden jerky pupillary constriction during hydrodissection, sudden deepening of anterior chamber, transient movement of pupillary margin inconsistent with anterior chamber manipulation by instruments, and relative inability to rotate a previously mobile nucleus. Now let's look at this case. After the rhexis, you're doing just a normal hydro, and you can see that snap sign. Now this is a classic pupillary snap sign, which if you're observant, you know that you had it. It's time for you to go ahead and change your, go to plan B as far as dealing with that nucleus is concerned. Now this is a case of how you will find your pupillary border with the unusual tremulousness. Watch it again, right in the beginning of your case. You just eat through your nucleus and you have touched the PC, and then you notice this. Now, these are the cases that really need to be handled right at that moment when you notice it. That means, as a FECO surgeon, one has to be very, very observant. Now, continuing with the cardinal signs of torn posterior capsule, there's sudden difficulty in burying into the nucleus and a tendency for the nucleus to display a vibratory or tremulous movement. Now, the surgeon has to be very careful with these. Excessive tipping of one pole, the partial descent of the nucleus, meaning after all the signs are given by that particular nucleus, if you still do not get it, finally you will see a descent of the nucleus, and obviously one should not wait till then. So let's talk about the management part. The primary objective is a safe and thorough cleaning of vitreous and lens fragment from the anterior segment. That's our primary objective. And the secondary objective is the stable placement of an intraocular lens for most appropriate refractive results. So the factors affecting your decision making would be first and foremost the extent of rupture and the stage at which the PCR has occurred, the location and the size of the nucleus, and most importantly, what is your plan B and whether you have an availability of VR backup. Now, all these things together will help in making your decision. Then what should be your management strategies? First and foremost, identify the tear at the earliest. Now, be quick with your non-dominant hand to inject visco before bringing out the FECO tip. That's very important so as to contain the PCR. Be careful not to enlarge the tear during this process. Take a call regarding how to proceed after assessing the extent of the damage. Now, if the decision is to convert, and that decision would depend on the stage of cataract surgery, the amount of nucleus left in the eye, the size of the posterior capsular rupture, the presence of vitreous in the anterior chamber, the hardness of the nucleus, and other accompanying risk factors like small pupil, loose venules, and all that. But finally, if the decision whether to convert or no would depend on individual surgeons' level of confidence and expertise, or the backup service that he has in a place like institutes or where multiple surgeons work. Now, managing FECO, managing PCR, and when you're doing FECO, you have to use dispersive visco before the removal of FECO tip, as I said before, additional visco below the nucleus to lift it up, and cautious FECO with low parameters. Now, let's look at this case. Now, here the resident is at the last stage of his FECO, but he doesn't realize that, especially at such moment, your control on your foot switch has to be very, 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 very gentle and guarded, and your parameters have to be low. So what do you do here? First thing, you keep your FECO tip there, you come out gradually, inject viscoelastic. Once you inject viscoelastic, what you do is you block that vitreous from coming into the AC. Like in this case, the surgeon has acted before the vitreous had any chance to come into the AC. So to a large extent, the surgeon manages to block it and then fill the AC with viscoelastic above the nucleus, below the nucleus, and then through a side port, you get your nucleus in the safest zone possible. For you to do FECO, this is the safest position where you take that fragment on top of the iris. Now, there are two options. One can go for a vitrectomy straight away, or if you think you can manage to get the cortex out before going with vitrectomy, that's better, because the moment you start doing vitrectomy, most of that cortex sometimes starts sinking into the vitreous body. And here, because you have blocked your vitreous with viscoelastic, you are able to remove that cortex. And after the anterior vitrectomy, you go and try and get some of those loose cortex that's there in the back. Fortunately, in this case, the PCR is small and well circumscribed. So the option in front of me is either to use a lens scaffold and get the nucleus on top of it and complete. Some of you would say that if you have to use a lens scaffold, why use a single piece? The reason I use single piece here is because I'm very sure I would be able to get this lens into the bag at the end of the surgery. So once the lens is giving you support from behind, getting that nucleus out is not an issue at all. Once that nucleus is emulsified, you fill the eye. Now your job is to ensure that the lens goes properly into the bag. So use your hooks to open it selectively at a place where that haptic really needs to go into the bag, which is easily possible. And luckily for that resident, here the PCR was well circumscribed. So this was one case that I thought I would share with you. Now this is the second case. Now this is a case that I did. In this, I misjudged the FECO parameters. And when I see this, that's a time I wait, inject viscoelastic. Now the second load of viscoelastic that I inject is between the rhexis margin and the nucleus, so that I want the viscoelastic to go behind the lens, behind the nucleus, and stay there as a support. After that, like in our olden days when we did SICS, you go with two instruments, use your spatula and your dialer, and try and get the entire nucleus out of the bag. You can even get it supracapsularly in the manner that I'm showing you here. Once you do that, try and inject some more viscoelastic behind to block the vitreous from coming forward. Now this is a 2.2 incision. You use a 2.8 keratome and enlarge it, and use the popular scaffolding, where this time I'm using a 3-piece. A 3-piece lens is inserted and kept either in the sulcus or in front of the iris. And once the lens is properly placed, continuing with FECO is just routine stuff, because there's no fear that the nucleus will fall into the vitreous. Once you have done that, you inject triamcinolone, check for the vitreous that is disturbed and that has come in front. This was done some time back. If I do it today, I will use a trocar cannula and go through pars plana. That way I would avoid, I would have much better control on the amount of vitreous that is cut. But even here, I'm able to do it pretty well, and the anterior segment looks clean. There's hardly any fall of cortex in this chamber. And then, if I'm lucky enough to have a rhexis, which is not very big, once the lens is placed properly in the sulcus, I try and capture the optics, inject the pilocarpine, constrict the pupil, and ensure that the haptics are not tucked anywhere other than in the sulcus. So after the nucleus is managed, the cortex needs to be, cortex removal in the presence of vitreous. You have to use a vitrectomy cutter. It is used in two ways. You use as cut IA mode for vitrectomy and IA cut mode for cortex aspiration. That's very important. You have to reset it. Cortex removal with a low flow and low aspiration. Aspiration tip is brought in contact with cortex before initiating the aspiration. Now, when it comes to IOL selection and placement, if you have a small PCR with successful PCCC, you can definitely use a single piece in the back. If you have a larger PCR but intact rhexis, you can use any of the multi-piece in the sulcus with optic capture. If you have insufficient capsular support for PC IOL placement, then we have an array of lenses like iris clips, spiral fixated, glued IOL, any of those. But if you get a drop nucleus, either complete or even a piece of that, depends whether the nucleus is hard or no, one can complete the anterior segment, put a lens in the sulcus, and close the eye and send the patient to a vitreoretinal surgeon, or you can always leave the patient, fake it, and once the vitreoretinal surgeon manages it, the secondary IOL can be put later. So in conclusion, PCR can be avoided if you expect it and proactively take necessary steps to avoid it.